Dr. Kunjumadin. Thank you to Team Perindalmana ONG Society for the opportunity to make this presentation. It's probably the last presentation of the day, but then again, I cherish very much the opportunity to be able to speak among such wonderful speakers and such distinguished speakers. My topic today is pregnancy and fertility in thyroid disorders. So now, like how this is the last talk of the day, many a times this about thyroid, it is one of the last, sometimes we miss it out. Just in the middle of all our technical niceties and fineness, we miss out this thyroid. But then as far as reproductive health, pregnancy is concerned, we must remember that the thyroid and the thyroid disorders affect across a span. It affects the ability of a lady to conceive. It can affect the course of a pregnancy and also continue its effects postpartum, both hypo and hyperthyroidism. So it has got its effect around a span of things. So my talk, we shall just go around step by step, little bit about physiology. Then we'll come to pregnancy-related changes. Then we'll just have a look at the hypo and hypothyroidism, and then finally just touch around, how it impacts on infertility. Because I think there isn't enough time to cover through all these, all the things. Just regarding physiology, that this is a picture which all of you would be probably very familiar with. Important to understand that the thyroid gland doesn't function in isolation. It functions around an axis. Yeah, it functions around an axis, and then you have your hypothalamus here, which is going to secrete your TRH, which is going to then come down, act on the pituitary. The pituitary will secrete the TSH, and the TSH is the most important probably, because as all those obstetricians and gynecologists, we would recognize that TSH is the one which we use for measurement as an index of thyroid function very often. And then the TSH, it acts upon the thyroid gland, and then there you have an output of T3 and T4, which are very much interchangeable hormones. And then, that's where the importance comes. The T3, T4, thyroid is the jack of all trades, as they say. It acts on the increase the BMR. It acts to increase the growth hormone. It increases the body heat, the metabolic rate of the body. It's a jack of all hormones. You should understand that, and that's where the importance lies. And then once you have your T3 and T4, then you will see that if you look at the axis, then you will go, and then it goes a little bit backwards. It acts back on the hypothalamus pituitary axis, and then it will give a message to the hypothalamus that you slow down. Just slow down a bit, because too much, an infinite amount of TSH is not good for the body. So that's a little bit about the physiology of the thyroid. I think most of us will be familiar with this particular slide. Then you come to pregnancy, and then pregnancy has a little bit of difference in dynamics. Now, when it comes to pregnancy, the game changer here is, as you can see, it's the estrogen here. Yeah, you can see the estrogen right here. Yeah, that placenta secretes estrogen, and when the placenta secretes estrogen, you find that the estrogen increases the amount of the thyroid binding globulin. That's easy to understand. Then it will bind to the T4. The thyroid binding globulin would bind to the T4, and there would be less amount of free T4 available. That would be conveyed, and then the TSH. So see, there's this link here. So you have to remember the estrogen increases thyroid binding globulin, and then you have to remember there's another hormone here which is secreted by pregnancy from the placenta called the HCG, which is also, it's structurally similar to TSH. So because of that, you will have action on the thyroid, and it changes the dynamics of the thyroid in a bit. You will understand when I speak about hyperthyroidism, and then I will say about HCG related hyperthyroidism. Then here is where it is, because HCG is similar to your TSH in structure. Then it will again has the effect to act on the maternal thyroid and increase the thyroid hormones. So this is suffice to understand. And once you've listened to my previous slides, then you would understand this slide better. That in physiological changes, you have increased serum estrogen levels, you have raised HCG, and increased iodine clearance. So you would have, the TBG is more, T4 and TSH would reduce. So that's how the whole maternal thyroid physiology changes in pregnancy. What about your fetus? Now, in the fetus, why the thyroid is so important is important to understand that fetal thyroid development, even the primitive stages, just start around the 9 weeks. It's just around starting at 9 weeks. So first 8 weeks, there's nothing. By 9 weeks, it's the gland development, and then TRH begins to detectable, that is hypothalamic. Then at 12 weeks, you have iodine trapping. Then 13 to 14 weeks, you have thyroxine production, and it takes around 20 weeks for the full, the thyroid function to establish in the fetus. Now, this is very important to understand because all this time, the fetus depends upon what's happening in the mother and the thyroid levels in the mother for all this thyroid development. And that is where the thing lies, why you should have your thyroid levels so much under control. Because of this, once your understanding of this is right, you will understand why controlling of thyroid levels are important. Now, this is another slide which you should understand, that this is the placenta is demonstrated here. Your T4 will grow across the placenta, your T3 will grow across, your TSH doesn't go across, but all your antibodies, they go across. So when you have your Hashimoto's or when you have your Graves, you remember that all the antibodies cross here and they can have effect on the fetal thyroid directly. Okay, they'll cross the placenta and have effect, but the TSH doesn't cross the placenta. This is another small thing that you should understand. Now, in pregnancy and pre-gestation, always we are trying to maintain a thyroid levels around 2.5 to 3. That's what all of us have learned. Many a times we are confused as clinicians. Yeah, this is a spectrum of disorders that you have in thyroid in pregnancy. You can go from hypothyroxanemia to hypothyroidism, a subclinical hypothyroidism, hyperthyroidism, and a subclinical hypothyroidism. It looks very confusing. So, as a reproductive medicine person, and even as a obstetrician, what can you can have this one. I have one of these printed on my consultation tables and I keep it. It helps me a lot because it helps to identify what the problem is. See, basically a euthyroid patient will be normal. So if you learn to just look across here, you're looking at the free T4, you're looking at the TSH. So just connect the dots. A primary hyperthyroid will have a high FT4 and a low TSH. Similarly, a primary hypothyroid will have a high TSH and would have a low FT4. Once you just have this diagram, and I tell you it's a trick, to get across too much of this, getting into too much of this endocrinologist domain. So once you know this game, you're done with it and you're through. Now we'll come to specific disorders regarding hypothyroidism in pregnancy. Now there's something called overt hypothyroidism and there's something called subclinical hypothyroidism. Okay, the overt one is around 3,000 pregnancies, mostly Western data. Indian data says that there's more incidence in developing countries of overt hypothyroidism, and then always there's 2 to 5% of subclinical hypothyroidism. I'll come to that in this. Yeah, this slide explains what I mean by that. In subclinical hypothyroidism, you would have a high TSH, but your FT3 and T4 would remain normal. But in clinical, you would have a high TSH, but your FT3 and T4 would be low, normal, low. So, these two you should understand why. And then there are different types of hypothyroidism. There's primary, there's secondary, tertiary hypothyroidism, there's iatrogenic, and there's environmental. There's a reason for each one of them. Now, in developed countries, if you look at Western literature, they're mostly talking about hypothyroidism caused due to Hashimoto's. Remember H for H, so Hashimoto's causing hypothyroidism. But in countries like India, still it is iodine deficiency that is one of the most important causes of primary hypothyroidism. Other causes are subacute thyroiditis and maybe thyroidectomy or radioactive iodine treatment, but iodine deficiency is the main cause. While in developed countries, it's Hashimoto's thyroiditis. Okay, so now just a bit about this Hashimoto's thyroiditis. What is it? It's an inflammatory disorder where it's more common with those with other autoimmune disorders, and it causes transient hypothyroidism and almost 100% associated with anti-TPO antibodies. So if you want to differentiate between iodine deficiency and Hashimoto's, you measure this. If it's possible, it's Hashimoto's. And another point to remember is on examination, Hashimoto's patients will have goiter. They will have rubbery consistency glands, moderate in size. It will be mostly bilateral and painless. So Hashimoto's thyroid, that's how you differentiate between the two. Here it's simple. The T cells recognize the patient's own thyroid antigens as foreign, and so there's a block on the action of TSH leading to your hypothyroidism. Okay, so there's lymphoid infiltrate, germinal centers. So that's about it. More commonly in countries like India is iodine deficiency, which affects almost 38% of worldwide population. So, iodine rich food, if you don't take, it happens. Important is that it's one of the important causes for congenital cretinism. I told you, the fetus requires the maternal thyroid for its development at least up to 12 weeks. After that, there's a takeover. So if it doesn't have, then, it affects the brain development of the fetus. There's growth failure, mental retardation, and neurophysiological defects. So very important to correct hypothyroidism in pregnancy. Then there are these rare conditions. I won't stick much on these slides. They are rare conditions, the granulomatous thyroiditis or the subacute lymphocytic thyroiditis. We shouldn't stick much or think much about it. Think about the iodine deficiency hypothyroidism and learn to differentiate it from Hashimoto's thyroiditis. We should also learn to understand this. Sometimes we find, subclinical hypothyroidism. What is the TSH levels are elevated, very commonly found in our clinical scenarios. TSH levels are elevated, and there's normal FT3 and FT4. Once the TSH is elevated, you will check your FT4, but that's normal. But the elevated TSH. So 30% or 40% of these patients will have anti-TPO antibody, and then these subclinical ones will ultimately, half of them will progress to hypothyroidism in a period of time. But it's important to correct this one also, because it may cause a childhood IQ decrease, and so that's important. Okay, that's a little bit. Now those are the easy ones to understand. There's also something called secondary hypothyroidism, the TSH deficiency because of pituitary problems. Okay, I told you that TSH comes from the pituitary, so pituitary problems, or the tertiary hypothyroidism caused because of hypothalamic problems, that is damages the hypothalamus or HPO axis flow. So these are rare conditions. So if you see maybe 1,000 to 2,000 ladies, you may come across one of such cases. So, and then there are also some medicines which cause hypothyroidism. We are here on hypothyroidism. So these are a few of the medicines, just ferrous sulfate, sucralfate, aluminum, the antacids, and these sort of medicines, they cause a decrease in the hypothyroidism. How do you know this about hypothyroidism symptoms? The symptoms are so many because of slow metabolism. I told you thyroid is a jack of all hormones. So PMR, or the metabolic rate of the body, depends upon thyroid. So when there is a slowing of metabolic process causing lethargy, fatigue, cold intolerance, then there's deposition of matrix substances which would lead to dry skin, hoarseness, edema, all this, and others such as decreasing hearing, depression, all this, all related to your metabolic activity you attribute to the thyroid hormone. More important than the symptoms, what is to understand is that it overlaps with pregnancy. So if you are trying to do only many times you get confused because fatigue is there for a pregnant lady. Otherwise, also there's some amount of constipation. All these things are overlapping with pregnancy. So it's important to screen patients for thyroid deficiency. Otherwise, if you just go symptom wise or you wait for symptoms to appear, you may miss hypothyroidism or you may miss overt hypothyroidism. That's why the screening of this disorder in pregnancy is very, very, very important. Why is the screening, and why is what happens? What happens if you were to treat and hypothyroidism? What happens in the pregnancy itself? That's from a very good study that was done. There's a lot of disorders. You could have preeclampsia, placental abruption, PPH, miscarriage, gestational diabetes. All these things could happen, and even subclinical hypothyroidism. All right, it's not only about frank hypothyroidism. Even subclinical hypothyroidism can give you a miscarriage, can give you preterm labor, and then of course the fetal and neonatal consequences such as reduced IQ to frank mental retardation. These are all defined as effects of thyroid on pregnancy outcomes. So it's important to treat. And always think about the baby, and always remember the physiology slide that I showed you, that fetal development up to 12 weeks there is no thyroid production. It's all after 12 weeks. So there is bound that if you have frank hypothyroidism, it can cause negative effect on fetal intellectual development. There's a high incidence of low birth weight babies, and then there is hypothyroidism, congenital cretinism, and all these things. So once you have passed 12 weeks, if you haven't detected it, then probably that the damage would have been done. So screening of thyroid disorders in pregnancy is very, very, very important. Once you've diagnosed thyroid, I think all of us know if a patient is hypothyroid, you would substitute with levothyroxine on an empty stomach. Very important to follow up and recheck every 4 weeks, or and if it's normal after every 6 weeks. Okay. If the patient was previously hypothyroid, increase the L-troxin by around 30%. Your treatment goals should be to bring the levels between 0.3 and 3. We'd like to keep it between 2.5, 3. There are different, the American Thyroid Association, the ACOG, which keep on varying these figures 2.5 to 3. Rather than stick to a figure, it's more important to understand the concept behind why treatment of hypothyroidism is so important, especially in a country like India. And then keep checking every trimester. Remember that it's safe in pregnancy and lactation. Don't have any fears about that. And then, yeah, it should be monitored every trimester until delivery. That's very important. Now, if you replace with thyroid, can the patient have a few problems? Yes, patients report a few problems like this. Their cardiac activity, irritability, sleeplessness, tremors. These are all there, but they are. You should remember that they are not part of the problem. But these can happen because of replacement with thyroid. Because once the body starts getting the thyroid, again the basal metabolic rate and activities do start increasing. So that's important. Now, you should remember that these take-home messages, that the commonest cause is Hashimoto's deficiency and iodine deficiency, TSH. You should remember that if it's high, you should test for that, keep your antibody to take out Hashimoto's. You should remember that thyroxine is beneficial, and postpartum again the checkup and follow-up is required for these patients, and some of them are prone to have hypothyroidism in the long run. So it's important. Once we've covered hypothyroidism, by and large, we come to hyperthyroidism now. Now, hyperthyroidism is again there in pregnancy, but it's much more less in incidence than hypothyroidism. That's important to understand. Like, you would have to have seen around 3,000 or 2,000 pregnant ladies to catch patients of hyperthyroidism. It's not so common as it is hypothyroidism. But then, if you ask yourself a few questions, you would catch these cases easily. Like, should a pregnant lady be losing weight? She shouldn't be. Should a pregnant lady, the weight remain constant? No, she should be increasing her weight. You should then ask the lady that, has she lost her appetite? If she tells you, no, I'm eating a lot of food, but still I'm not gaining any amount of weight, then you should have an index of suspicion that, is it hyperthyroidism? Now, I said that hyperthyroidism can be caused by two reasons. You should remember two things. One, you should remember is what is called as Graves' disease, which is commonest cause of hyperthyroidism in pregnancy. And you should also remember HCG related hyperthyroidism. If you listen to my slide on physiology, HCG I said was structurally similar to TSH, and HCG is secreted by the placenta. So there's something distinctly called HCG related hyperthyroidism. What is that? Is sometimes, even sometimes these patients have twins or triplets, and just because the amount of HCG is high, then they would have some element of hyperthyroidism. Sometimes you have gestational trophoblastic disease. That's not a pregnancy, all right, but there is increased HCG and they will have hyperthyroidism. But the commonest one is Graves. Okay, the commonest one is Graves. Now, in Graves, when the patient comes, you would like to know that you screen and you feel that this patient is hyperthyroid. You are starting to think that, is this Graves disease or is this HCG related hyperthyroidism? Now, remember, these are a few pictures which show what happens in Graves. Okay. Now, Graves, you have this amount of goiter, you have this lid retraction, pretibial myxedema. See this, all these things which are highlighted in red are there in Graves. This is more severe one. That is, you have this exophthalmos, and that happens in Graves. It will never happen in HCG related hyperthyroidism. So that's how you sort of differentiate between the two conditions. Otherwise, there are a lot of symptoms like nervousness, tremor, tachycardia, hypertension. They'll all be there. But this goiter and then this lid lag and this pretibial myxedema, these shanks, this typical sort of rash, it happens in Graves. Okay. Now, when you're looking, yeah, this is the one which I was telling you about HCG mediated hyperthyroidism. There's excess, and then, there are some conditions like excess TSH production, toxic goiter, and some extra thyroid sources of thyroid hormone, which could be other causes, but the most common cause is Graves. And in Graves disease, you would have elevated FT4 or elevated pre-thyroid index with suppressed TSH in the absence of the goiter or mass. Most patients have antibodies to TSH receptor. There will be antimicrosomal or antithyroid peroxidase antibodies. If you measure them, you'll get it out. So that is the way you differentiate between the two. What would happen if a patient with Graves disease would continue? You should remember that it can cause multiple complications of pregnancy like preeclampsia, IUGR, preterm labor, cardiac failure, stillbirth, and fetal and neonatal hyper and hypothyroidism. Remember what I said, the antibodies. Most patients with Graves disease will have antibodies, and antibodies could cross the placenta and cause disastrous effects on the baby. That's why you could have your preterm labor, IUGR, stillbirth, all these things, imagine what would be happening in those conditions. So, yeah, so that's important to diagnose this condition because of all this. And you could also have the risk of fetal thyrotoxicosis, immune mediated hypothyroidism. All this is possible in if you leave diseases untreated. So what do you do is to treat. You should remember that there's a group of drugs which are called thioamides, which are the treatment. It's polythiouracil and methimazole. But PTU or polythiouracil is the drug of choice. Is the drug of choice because especially up to 16 to 18 weeks, it does not have any teratogenesis, and so it is traditionally preferred. And remember, the goal is the main is never try to overcorrect. Always, what you try to do is you optimize in the high normal range using the lowest possible dose. You minimize fetal exposure to these medicines and then measure the levels of thyroid every 2 to 4 weeks and then titrate the doses according to what is necessary. Now, what do you happen when you treat and what happens to the fetal thyroid is there would be a transient suppression of thyroid function. There would be a thyrotoxicosis due to maternal antibodies. It's rare, but it's a possibility you should think about. And hence, these patients often require consultation with an endocrinologist. It's always better that we don't try and treat the hyperthyroidism cases on all by our own. And also, it requires a multidisciplinary consultation. You have to notify the pediatrician also because the neonate will be at risk for thyroid dysfunction. So, and there's fetal goiter also associated with Graves. So, but it's important to remember that breastfeeding is again safe when you're taking polythiouracil or methimazole. Also, remember, patient is symptomatic, and depending upon symptoms, you can offer treatment like beta blockers. But reserve thyroidectomy for women whom all treatment is unsuccessful, and reserve iodine treatment as much as possible, especially in pregnancy. Now, the ATA recommendations are there that, subclinical hyperthyroidism does not need treatment. You can just check again. You have, those who are euthyroid with antibodies need monitoring. Look for fetal thyrotoxicosis. Ultrasound features of fetal thyroid dysfunction like IUGR, hydrops, they have to be followed up. And antithyroid drugs are to be given to the mother and fetus and monitored after 2 weeks. So these are some of the guidelines, which I think each hypo and hypothyroidism is a lecture by itself. Now we are running through it because of time constraints, but it's important to understand. At least at the end of the lecture, we take home messages that it's important to screen patients, diagnose early, follow up on these patients, and many a times multidisciplinary treatment is required. Now, as a reproductive medicine specialist, many a times often we are obsessed about thyroid from all angles. The thyroid is responsible for anovulatory infertility, recurrent abortions, infertility due to endometriosis, and autoimmune thyroid disorders. So, we as reproductive medicine specialists do